This excellent medical student-led podcast is for educational purposes only and not intended to be used as medical advice under any circumstance.
We are back for episode 17. I'm excited for many reasons. The weather is beautiful today in Chicago, and we have two guests who are returning, which I think is a first. And I'm excited because I'm going to introduce them as Dr. Levinson and Dr. Stathopoulos. And you remember them from earlier on in our cases. John, both Dr. Stathopoulos had a case that presented as dysphagia. It was occlusion body myositis. And Dr. Levinson had a case that I think, if memory serves me correct, ended up being GPA.
Yes.
So we have a doozy for them today. We are a week from graduating and starting the next chapter of our lives. I'll let them just say hey, and they can tell us what your guys' plans are before starting residency, and then where you guys are going to next.
I'll go first. So, there's two of us Johns here, so it might get a little confusing. We've actually rotated 3 times together, and we've been infamously known as the Johns, since we're the only 2 people in our class that go by John. But yeah, so I will be starting an internal medicine residency at Loyola this July, which I'm very excited for. And before then, I'm just hanging out with my dog, being a dog dad. And then in June, I'm going to be going to San Francisco and LA to visit some friends out there.
Very nice. I'm going to do internal medicine out at Portsmouth Regional Hospital in New Hampshire. In the meantime, just enjoying all of that which Chicago has to offer. I enjoy rock climbing, so doing that. And yeah, going actually out to the West Coast as well to see some friends and family there. And yeah, just enjoying the time.
Awesome. Excited for you guys. Dr. Abrams, what's been going on with you?
That much, although I'm intrigued that John's been climbing the rocks here in Illinois.
They are plastic rocks, so they are at a gym.
The other nice thing is I think of it this way: so you guys are at the peak of your knowledge.
Oh, it's
I don't know about that, Dr. Abrams.
Today is the peak, or this week is the peak, and I don't want to say it's downhill from here. Hopefully, it's uphill over the next couple of years.
Absolutely.
So, we're really sort of excited, proud of you guys for reaching this point, and you're going to be great with this case.
So our first aliquot, we have a 20-year-old male. He's admitted after presenting to the ER for evaluation of 30 pounds of weight loss over the past 3 months.
So since the last time I've been on this podcast, I actually started listening to the clinical problem solvers a little bit.
Amazing.
So this amazingly came up where I think he calls it the high five sign, where if your first instinct isn't to give them a high five, you're proud of their weight loss, then usually something's kind of wrong. And 30 pounds over 3 months, I would not give someone a high five. So that's definitely concerning. What do you think, John?
Yeah, I think that's a really great point. Yeah, I guess at this point still, it's like, it just seems so vague. So definitely ask them, was there an intentional component to this at all? Just kind of see and, kind of get a more, obviously, I'm sure we'll get there, more broad review of symptoms. So definitely.
And just like overall, I guess, big categories to think of. 3 months is even that quite chronic. So I guess any kind of malignancies jump into mind. I don't know, even like 30 pounds for infection seems kind of fast. Over 3 months even seems fast for that too.
Yeah, definitely.
So
I would think also endocrinopathies obviously could contribute to that. And I think also more so in a 20-year, if it were a 60-year-old, I think my differential would be more oriented towards malignancy. But in a 20-year-old, I also would consider psychiatric components, also, medications, any drugs that they've been using.
You guys are talking like seasoned clinical reasoning pros. I have nothing to add. Let's go to the next aliquot. So a little bit more. He developed fever and chills at the time that he began to lose weight. He initially thought his symptoms were due to COVID, but self-tested himself twice. Results were negative. Sometime later, we don't know, his fever resolved. He denied rash, joint pains, swollen or tender lymph nodes, had no GI-related symptoms, including nausea, vomiting, diarrhea, or constipation throughout the 3 months. No remarkable family history. He doesn't drink any alcohol. He does smoke marijuana on occasion. Does not use any other recreational or over-the-counter drugs. He is sexually active with one partner and did note that his ejaculate had been more yellow in color.
I think with fever as a reported symptom. I think definitely infection is on the differential to an extent. Interesting about kind of that sexual note that he noted regarding his ejaculate. So I think maybe an STI of some sort could be on the differential, like a pelvic and just STI of some sort.
And then so is he continued to have fever and chills since getting COVID, or was it he had COVID, fever, chills, then it went away?
So he thought he had COVID, but tested and didn't end up having COVID.
Okay.
He did have fever throughout these 3 months that seemed to resolve on their own. So the main complaint for him now is the weight loss.
Okay. And then also something we could think of is autoimmune in general. There's
definitely
a cajillion. Lupus does a kind of a billion different things. I guess we just want to start out basic here, get like CBC, CMP.
Yeah.
Get a like thorough physical exam and kind of go from there. And
Exactly.
I think some of it could be like there could just be, I think the STI could be something not related. He might just have an STI. Who knows? But obviously we should I think you mentioned STI panel.
Yeah. Yeah, that sounds great. I think it's the lymph node comment is always something that sticks out because lymphoma could definitely be something we're concerned about in someone of this age with this weight loss. But I guess obviously not all lymph nodes are superficial to the extent that you can notice them on a physical exam. So I'm sure we'll kind of get to more imaging possibly later on.
That's a great point, John. I'm going to challenge you guys. And you've mentioned STI, which I think base rate wise should jump up on the differential based on the unique finding we have. Does anything else, or what other things come to mind that could change color and or appearance of ejaculate?
Maybe some, besides just like an STI,
Yeah.
I mean, some kind of weird fistula maybe from the, like, that's coming between like my anatomy, my bladder to the wherever I apologize, everyone. My anatomy is rough. I've been studying up anatomy. I'm not a neurologist.
Yeah.
I think what you're getting at is like
Some kind
of urine could be
Yeah.
contributing to
definitely. And I think it'd be interesting to ask him, does he have any blood in his urine? Does he note that his urine, has that been any different either? Just does he have any pain when he urinates or anything like that?
all good thoughts.
I am really sort of blown away. No, I'm serious. I'm blown away listening to you guys reason, and you're doing it. I mean, you're doing it both logically and kind of effortlessly. That's, to me, that's the cool thing. Is it just seems so easy for you guys right now.
They're so smooth. I have no probing questions. They're like hitting everything, telling me what they want next, why or what they're looking for. This is great.
I think that's why we're both going to medicine. We just love discussing this stuff and really just engaging.
Let's give you guys some more. So physical exam, blood pressure 123/78, heart 90 beats per minute, afebrile, normal respiratory parameters. The exam is, I'm just going to skip all the good stuff. It's nothing to add.
I always have to think a little bit, forgive me, just, converting kilograms into pounds. I think 60 kilos is, I don't know the exact, but I think I'm probably somewhere in that range. So 60 kilos is probably 160 something.
About like 135.
2.2 is the number I always remember.
Okay.
It's about one, a little under 135.
Okay. Does he appear cachectic or anything on exam?
No.
Okay.
Yeah, so the physical exam is normal. So, but I agree, the weight loss 135, I guess, depending on his height, but still with the weight loss.
Sure.
Yeah, I think the biggest thing is try to go to like CBC, CMP, see if there's anything going on. Like you look at like any kind of lymphocytosis, anything like that.
Totally.
Any just abnormalities we can pick up on. Because I think one of the things you think about young people in this age group, a lot of it, I'm pretty sure leukemia was like AML is pretty common among this. I think it's, don't really do peds, so it's making this hard. But there's things like that that are jumping to mind. I'm still like, my brain is like, if I had to get like, put my money down, I think it's some kind of malignancy.
Okay.
Yeah, I think I'd be at malignancy versus infection at this point.
And again, Kevin knows I say this all the time, and that is sometimes physical exam is meaningful, right? Because it says either you did a bad physical exam or somebody did a bad physical exam, or they did a good physical exam. And so there's absence of findings on this exam
Definitely.
that are meaningful for thinking about what the diagnosis.
Totally.
Let's do some lab data, and this is going to be the aliquot, so we'll break it down. His electrolytes were normal, creatinine was 5, and glucose was 102. The CMP did reveal an AST elevated at 134, an ALT elevated at 119. The alk phos was elevated at 347, and his T-Billy was 4.2.
Yeah.
Total protein came back at 8.5, and the albumin was 2.7. ESR was also checked, and that was elevated at 40. And then on CBC, there was no leukocytosis, no anemia, no thrombocytopenia. And then some basic infectious workup was done that included HIV, acute hepatitis panel, and a monospot, which were all negative. And then EBV serologies, the IgM was negative and IgG was positive.
It's funny. Last time I was on here, I remember we had elevated liver enzymes, and we were quick to point that out, and it was like, well, kind of keeping in mind that you don't just see AST and ALT only in the liver as well as alk phos, but kind of looking at that, it does seem more hepatobiliary in nature to me. I know, one thing that's drilled in med school is, the ratio of AST to ALT for alcoholic hepatitis, which they kind of boast a 2-to-1 ratio. I don't think this is quite there, but AST 134, ALT 119, alk phos 347. But yeah, I think that T-Billy is pretty notable to me. When I think of elevated total bilirubin, I can think of hemolysis. Then I think of, hepatobiliary pathology, and I'm sure maybe we'll get into a conjugated versus conjugated to see exactly what process is going on. And then also, obviously, the albumin sticks out to me. It seems like I can't really classify too much more at this point, but there's an inflammatory process going on to cause that albumin to be so low.
Yeah, and I just calculated an R factor because I just remember that we were actually on hepatology together and we're talking about that. And I put it in there, which for I guess people don't know what it is. You can do it at MD Calc. And you put in the patient's ALT, alk phos, and it came back with the ALP is very high, double check. So that's always a red flag, something bad. And R factor 1, which pointed towards cholestatic injury, and they recommended abdominal imaging when it's that high. Yeah. And you think of things like that, especially in this age group. I remember we had a patient with
I remember
PSC which is a really horrible diagnosis.
I remember not much to do for PSC. It's just a really tough pathology to have.
Probably going to need a liver transplant. So hopefully that's not the case for this patient.
Yeah. I'm just trying to thinking out loud, John. Do you think PSC, that would be more chronic in nature, or, how would...
You're right. I would think that too, because I feel like that develops over time. And this is so fast.
Yeah.
Because even that patient, I remember it wasn't... I'm trying to remember how...
It's so funny. I remember that patient myself.
I'm trying to remember how it presented over time. I think he came for something completely unrelated, and they just did a CMP, and his lab values or something like this, and like, oh my goodness. And they end up having to do an ERCP, and that's how they diagnosed it.
It's been a while since I've thought of, microbiology that can affect the hepatobiliary tract, but I think that is also something maybe we can consider in a little bit, perhaps. I think the checking for mono is something, I didn't really think about, but something with weight loss, kind of perhaps like unexplained fevers, I think, mono is a good thing to check. Yeah. So that was, something that I recalled looking at this next aliquot.
I'm just going to probe you guys with this. John Stathopoulos glanced over at the albumin being low, and then I just want to highlight again that the protein's pretty high, so there's a gap. What do you guys think about that?
Oh, yeah. When you think of that, isn't that usually something seen with, like, those, like, multiple myeloma and those...
MGUS, yeah.
And those... Can't remember the term, some glomopathy, where that's concerning for that. Maybe we could do a calcium, try to look at that, because also when you think of things like sarcoid can affect the gallbladder, I guess kind of rarely, but kind of check on with ESR. I'm also thinking it's an autoimmune process that you have going on.
Totally. I think if we could also, I can't remember the name of the test, if kind of differentiate between the proteins, like an electrophoresis perhaps or something, to see if we can kind of further classify those proteins. I think that's a really good point that thinking of multiple myeloma. Obviously, with this patient pretty young, you wouldn't necessarily expect that, but, malignancy is definitely under a differential. So something we'd want to explore with, elevated total protein, low albumin.
Amazing discussion. Your guys' reasoning, again, is just so smooth. You both are framing it like how this changes your thinking, but then bringing back information we already have, such as patient demographics. He's 20 years old. It's so unlikely that he has multiple myeloma. And you're just reminding that, but noting like this finding is abnormal, and you're pushing yourself to think about it a little bit more deeply.
So I want to go back and ask you guys a question, and that is, you guys both took hepatology a lot more recently than I did.
Great rotation. It's
Yeah,
really
it's
fun
great.
rotation.
So I guess my question is how do you think about patterns of liver injury based upon liver function tests, or the basic liver function test that we see?
And so John mentioned earlier about the alcohol is usually going to be with the double of the AST or the ALT. And you think of acute versus chronic, where something really acute is going to be in like the thousands usually, or very high hundreds. This is high, but this isn't screaming like that, where it's like some kind of acute like all of a sudden he has a fulminant hepatitis going on, some kind of acute Tylenol overdose, especially with the symptoms going up for 3 months. So this is something that's going to be more of a chronic issue.
Yeah. One thing I'd be curious to check, I think it's always a great thing to check whenever we have concern about liver function, is the PTINR to see, you know, what the synthetic function is looking like. Because we have enzymes at this point, and the total bili, I think, is always really important to check. But I think PTINR is also somewhere else I'd want to go eventually.
And probably maybe get a ultrasound, like to just take a look if we could see anything, and then from there decide whether or not we want to do MRCP. But that's, I think that's further on right now.
Yeah, totally. All great thoughts.
Love it. So some time passed. He was referred to GI, and they noted him to be mildly jaundice appearing.
Not mad.
His electrolytes largely didn't change. Important thing to point out is his creatinine did bump to 1.75. His AST, ALT remained elevated. Alk phos remained elevated, and the T-bili bumped a little bit higher to 6.8. We have similar findings with the protein and albumin, with the total protein being high and the albumin being on the low side. CBC was largely unchanged, other than a mild drop in his hemoglobin from 13 to 11. Some other labs were checked, including a pretty basic autoimmune workup. ANA came back negative, RF was negative. C3 and C4 were both high at 234 and 66.5 respectively. They did do an SPEP, showed diffuse hypergammaglobulinemia. There was no paraprotein detected. The IgG was high at 1,798. The IgA was high at 382. IgM was normal. They did check a ceruloplasmin, and it was elevated at 64, with the upper limit of normal being 36.
Well, trying to think with Wilson's disease, I feel like his ceruloplasmin usually super elevated. Trying to think, 64, where are we at with that? Now, just looking at some more detail that we have some sort of kidney injury. We also have elevated C3, C4. We could think of a nephritic condition. Can't think of necessarily how that would explain the hepatobiliary picture that we have on board. And I'm just kind of going through the new data we have. We also have a mild anemia at 11, which is significant in my opinion. And then I think our MCV, we were at like 79 before. So maybe just slightly microcytic, but obviously this is kind of an acute, subacute, honestly kind of going to chronic picture at this point. So with many patients, we're not shocked to see a hemoglobin of 11.
Great point.
I'm trying to add, and I think just looking at the hyponatremia may be a sign of decreased liver function. From that, you can get with liver failure, you can get natremia, T-bili is going up. I guess when you think of other things like Wilson's disease, you think of the triad or some kind of psychiatric or dysfunction. You look for Kaiser-Fletcher rings in the eyes, which I guess I don't think you need necessarily opt out. We could just probably take a good look to see if you could see them. So we could do some probing to see if there's any psychiatric or neurological dysfunction.
I would say he definitely is at the age I would think of, when Wilson's disease presents. So that's a really good point, John. Yeah, and those IgG and IgA levels are pretty high.
Yeah, that is concerning.
So what does that make you think of?
I mean, the ones I think, there's like Waldenstrom's, that's more of like, if I remember, like that's a kind of hyperviscosity disease.
Yeah.
It presents to get like Raynaud's, and they can have like retinal issues, if I remember
DVT,
correctly.
yeah.
DVT, I think, and then something like that, which I don't know if that, maybe you could do some probing about that. I'm trying to think what else.
I think it can present with Bud Chiari. I'm trying to think. I don't know if that would necessarily explain like our liver picture at this point, but it's definitely a thought.
I don't want to give you guys a HIPAA violation, but my uncle actually had Waldenstrom's globulin, and you guys said he's the only sort of ultimate manifestation he had of the disease was he didn't come blind.
Really?
It is a like you guys said, hyperviscosity syndrome, usually associated with hyper IgM. Right? That's the sort of the traditional thought around it. I think you could tell me. I think it is always hyper IgM. It is always.
Yeah, I was gonna ask what you guys thought about it being not monoclonal, but we have IgG and IgA elevated. That helps your thought process at all.
Yeah, so it doesn't point in that direction.
And again, like diffuse hypergammaglobulinemia is kind of sticking out. So if you were thinking it's like a malignancy in the blood, I think I would probably expect it to be more monoclonal in nature.
Yeah, and like going back to the high ASR, you can get that from multiple myeloma. Again, the age is very young, and that kind of seems surprising for this. Let's see. Calcium or anything like that. I mean, he just doesn't have any history of fractures or anything like that. So it's on the back end of the differential, but it's not what I'm jumping at.
Okay. Next steps. What do you guys want to know more of?
I'm going to get some imaging of the liver.
Okay.
Yeah. I think ultrasound is where I'd start out.
Other things to think about. I think about people with diffuse hypergammaglobulinemias. There's infections that immediately come to my mind. Certainly the viral hepatitis C is one that sort of classically does that.
And hepatitis C could explain this patient's, obviously kidney findings that we're seeing. Mm-hmm. Can't remember. Did we test for the did we do a hepatitis panel already?
There's an acute hepatitis panel that was negative.
We got an acute panel. Okay.
The other thing I think about are, you guys have already mentioned it, sort of the blood immunologic sort of diseases. And clearly there's some information here about some of these diseases. Clearly not all of them. You've got your ANA. The significance of those elevated complements.
Yeah.
I guess I'm not sure what to think. I know what I think they're not, but I'm not sure what they are.
Can you explain though? What do you think they're?
Well, I mean, what you say, I mean, now you start thinking about hypocomplementic processes, and you say, what are the lupus is a classic one.
Yeah.
And so everything says, this is not lupus, or it's not a really close lupus-like illness, right?
So it lowers the connective tissue type stuff.
It changes the way I would think about what those
Okay. I like that. All right, let's go a little deeper. I checked your analysis. Significant for a protein of 1+. Ketones were negative. Bilirubin was positive. No blood or nitrites. Urobilin was 1.0, which is elevated. No white cells, RBCs, epithelial cells. No casts or bacteria. We did scan his abdomen. We had an MRI that revealed large clustered lymph nodes / lymph node mass in the periportal region extending up to the porta pavis. There were multiple other enlarged retroperitoneal lymph nodes noted, and he had mild hepatosplenomegaly.
I think for me at this point, my differential is lymphoma, like some sort of malignancy still versus infection. Still, I guess, autoimmune on the differential as well. I feel like when in doubt, I don't know if I'm jumping the gun. I think I would be curious to see a biopsy of those lymph nodes to see exactly what those show.
I agree. What was that saying? Yeah, is it tissue?
Tissue's the issue. I think Kevin. I can't remember who taught me that, but it may have been Kevin. I think Kevin or Charlie, but that's a story for another time. Yeah. So I don't know. Do you think it's premature to jump the gun and call? I guess probably IR at this point.
Yeah, I like to get a sample to see what's going on there.
Let's circle back to second aliquot just for talking. The yellow ejaculate. What do you guys think about that now?
Probably makes more sense now in the context of bilirubin.
Yeah. That was a knowledge gap for me. I never had thought about that, but it is something we see on the UA all the time, like urobilin. Good thing to think about now, I guess, if we have, it could be a presenting sign for someone that is having elevated T-bili.
Yeah.
And I may also ask you guys to comment more on your analysis and what this makes you think and what this makes you think it's not.
So I think like nephritic processes are off. So things or like are major nephrotic, like 1+ is like very minor. It's not something where before we saw the AKI, we're like, oh no, maybe it's like hep C causing some nephritic or mixed picture type syndrome going on. I think that's less on I think this is just from all the overall, like the hepatic or cholestatic dysfunction going on, leading to all the excess bilirubin going in, causing damage.
Yeah, that sounds good to me. I know we did check an STI panel. I would think that if someone has an STI, we would probably see some white blood cells in the urine. So that kind of confirms that for me. Yeah.
Tissue was the issue. The liver biopsy was done showing granulomatous hepatitis.
Wow.
A lymph node biopsy showed mostly blood with minute fragments of tissue showing granulomatous inflammation.
So I think going back to it, did I mention sarcoid earlier? I don't
think we mentioned sarcoid.
If I did, I was thinking it because I just think of granulomas, you think of that, and it can be in the cholestatic. It can kind of appear anywhere. I think to look at that, we can do an ACE level.
Yeah, that's great.
Go for that, which is weird that we're not getting any presentation with the lungs. Maybe take a look at a chest X-ray, see if we can see any lymphadenopathy.
Yeah. I think, sarcoid is such an interesting pathology because it can present in so many ways. I know the skin exam was mostly benign, and I feel like, especially in our board exams, that's something they really stress. That's not necessarily true because it can present so broadly. I'm trying to think of any other granulomatous diseases. I know TB is a granulomatous disease, which can present with weight loss and fevers, but I believe our patient didn't have any respiratory phenomenon or anything like that. Yeah.
Yeah. I like where you're going. What other granular pathologies come to mind?
It's coccidio. I can't remember.
Yeah, there's like chronic fungal infections, lungs, and then in this case, in the liver and the lymph node. It sounds like foreign body, but that's not in this case. It says we've seen that imaging, but there's some kind of history of trauma.
What about other non-infectious causes?
I think certain autoimmune diseases can.
So you guys mentioned already PSC.
Yeah, that's right.
We're nearing the end. There's just going to be a little bit more data. And they checked the quant gold, so they're also thinking about TV. They checked histoplasmin, so they're thinking about the endemic mycoses. Both were negative. Mm-hmm. Threw in an RPR, because why not? Syphilis can do anything.
Why not? Yeah.
It was negative. There was one more test that I think will reveal the diagnosis for you guys. So I'm going to challenge you before we get there to put your nickel down. Tell me what you would do next and what you think might be going on.
One thing, it's really funny that we have not talked about, and I believe we got did we get an MRI before? But one thing we haven't really talked about with weight loss, which is probably the most glaring, and I don't think that's what this is in this case, is a GI disease of some sort. Yeah. I think Crohn's is also a granulomatous disease, but I'm not sure if that really fits this presentation because he did not endorse any diarrhea or anything like that. But with weight loss and a younger person, I think Crohn's should be mentioned. But as we said, his review systems for GI was negative.
Yeah, and with Crohn's, I guess that's MRI abdomen is not the specific test you're looking for to do. That's like probably maybe see some type of strictures or something going on. But it's also what's tied is with PSC is ulcerative colitis. They're connected. I think I can't remember. It's some like if you have ulcerative colitis, you have a very high chance of developing. If you have PSC, you have a very high chance of developing ulcerative colitis. Right. It's like I can't remember. Quote me on this. It's like 70-80% or something. Very high. I can't remember the exact number. But I still am thinking. I think sarcoid is what makes the most sense with the lymphadenopathy. I don't think PSC really is tied in with that quite as much. Yeah. But I think those are my top two of my differential at this point.
I agree. I think PSC is really high up there for me.
Or maybe some weird kind of lymphoma. But but that the granulomas, that makes sense. You would see all those fun things like was it something the owl eyes, all those I remember from pathology from a few years ago where
so if you're thinking
Hodgkin's, but yeah, that we were seeing the pathology from the probably not there, but I'm putting my buck down. I'm going sarcoid.
I'm only smiling here because one of our very first cases was an older woman. I think she was in her 80s, and she presented with leg swelling, and that was her thing. That was her symptoms, and she turned out to have Crohn's.
Oh, wow.
Wow.
But clearly, she didn't have a liver biopsy that showed granulomatous hepatitis, which is, to me, is such a cool.
It is
such a cool diagnosis and differential diagnosis. And we haven't talked to, I'm sure we get the ID people out here and they'll be telling us about brucellosis, things like that. And you guys didn't ask if he,
It's a farmer.
pasteurized milk today, anything like that. I guess it's a bovine tuberculosis. Boy, there's so many things that sort of sit out there and come into that differential diagnosis.
Just before we move on from this, because I had to dig deeper on granulomatous hepatitis or hepatic granulomas, and the differential is much wider than I thought. It's infectious and non-infectious. We've covered a lot of them, but one category we didn't really cover viral. So HIV and infections associated with HIV can cause granulomatous hepatitis, but EBV, CMV, Hep B, and Hep C can also cause this finding. So just another thought. We can talk about it a little bit later.
And we didn't talk about meds because
Also, drug-induced liver injury.
drug-induced liver injury may be
Probably the most common.
people came to the end of all these cases that may have been the most common, and there's a whole slew of prescription medications that follows. To me means that there must be a whole slew of non-prescription medications or even over-the-counter medications that potentially can cause this condition.
All right. They checked an ACE.
There we go.
It was markedly elevated at 225, very likely suggesting the diagnosis of sarcoidosis and presenting as hepatic involvement versus pulmonary involvement, which are in the scripts, that challenges them. John L. mentioned he didn't think, the absence of any respiratory symptoms swayed him away from sarcoidosis, but these findings were unique enough to keep him on that train of thought. And ultimately, you guys got there and did it in such a smooth, expert way. I'm so impressed, and I'm just going to keep bragging because you guys have both been on already, and so we've got to sit in these seats and listen to you the first time you were both on, and you guys did great then. And I don't know, it's been just a few months, and your reasoning is exponentially that much more fluid and better. It's so impressive and so fun to sit in the seat here and listen. You guys have any reflections?
It was fun. It was good. And I was wondering how much medical information I've lost since, finishing my last rotation about a month ago. And glad that I still remembered something. So that was good. I'm glad we got to it.
I think for me, there are certain pathologies in particular that really can present so broadly. I feel like lupus gets a lot of credit for that, and syphilis gets a lot of credit for that. I think I would also throw sarcoid into that category. And for me, also endocarditis is something I think of when people are kind of having intermittent fevers with a wide array of manifestations. So I think sarcoid is just always something to have on your different, especially in this case when it's, coupled with some, some granulomatous findings on biopsy.
I can't say this because I know some follow-up on this case.
Yeah.
And follow-up is this patient was started on prednisone.
Okay.
Given a hefty dose of prednisone and returned, I think, 4 to 6 weeks later, and essentially almost everything had normalized by that time.
Wow.
And was slowly weaned off the steroids. And I know at the time that I could look into this person's chart that they were doing well. So
Good to hear.
really felt that this was the diagnosis and responded well to treatment.
I think what's so interesting with this case is, it's always funny after we go through this whole process to think about what the chief complaint was, and it was weight loss,
Yeah.
Because with sarcoid, you'd expect more respiratory, and with the fascinating hepatobiliary picture, you think it would be more abdominal pain and jaundice, but it was weight loss. So it's really interesting.
Just going to do some brief teaching points on hepatic sarcoidosis, and just some interesting things I came across is that it's thought that there's an oral to anal gradient of involvement, with 80% of cases involving the esophagus, stomach. It's very rare to involve the GI system. Hepatic involvement does occur in about 5 to 20%. The presentation varies based on the anatomic site, the stomach being the most common of GI manifestations, really non-specific symptoms. You got to think of other causes of granulomatous gastritis, though, if that is the presenting concern. So non-infectious etiologies such as Crohn's, infectious etiologies like H. pylori, TB, and then even idiopathic granulomatous gastritis. To highlight hepatic, the liver is involved in the majority of patients with sarcoid, although the clinical consequences of involvement are variable. So about 50 to 65% do have granulomatous on liver biopsy, but symptomatic hepatic sarcoid only occurs in about 5 to 15%. And interestingly, African American individuals are 2 times more likely compared to white individuals to have symptomatic hepatic sarcoid. Usually you'll see an elevated ALK phos and GGT. AST, ALT is increased, but less so than the ALK phos. Really nonspecific symptoms. The imaging findings are like what we saw in this patient with hepatomegaly and numerous hypodense lesions that range in size. And the pattern that is noted is they often do follow the portal tract. And like we've already discussed, you have to think about other hepatic granulomatous diseases because there's a lot of things you don't want to miss under the infectious. And then to nail a diagnosis of sarcoid, you need 3 big components: a biopsy that shows the classic non-necrotizing granuloma in the symptomatic or incident organ. You got to exclude other causes of granulomatous diseases, including mycobacterial, fungal, parasitic infections. And then there needs to be some clinical radiographic histopathoid in at least one other organ system. So good stuff to think about. Again, I'm so impressed with you guys. I'm excited for your careers heading forward. Thanks for coming back for a second round of this. I think it'd be fun. Let's get intern year under our another time to see
totally
how we do then.
Love to do it again.
Yeah, thank you, Kevin and Dr. Abrams.
I just gotta, we talk about autoimmune diseases in a very broad way, and I don't know what you guys think. I mean, this is something I read a long time ago, but I still think of it, and that is this concept of autoinflammatory diseases.
Yeah.
And what's interesting is I think there's different ways to think about those, but my mind is almost autoimmune diseases without autoantibodies. Think of them that way. And some people say they're T-cell mediated, and some people say they're granuloma mediated diseases. And these diseases, all 3 of them really fall into that group.
Yeah, they do.
And, there's a hereditary group, which is, I think, the way we all might have first learned about that. But there at least is some thinking of organizing some of these diseases around sort of that concept. And, we put labels on all of these things.
Totally.
I don't know the difference. I don't know the difference. Maybe they're all the same, for God's sake.
And I guess the question is, like, the treatment different, and it might not be in some ways.
Right. I think you're exactly right, John. And that is that the treatment of these diseases actually may be a little bit different, particularly sort of long term, because many of these diseases do become chronic. This person responded well to steroids in the beginning, but who knows if he's going to stay steroid responsive.
Right.
And so,
Yeah.
they in the back of my mind, they just hang together.
They do.
Sort of a way that makes me lump them into a sort of special category.
Absolutely.
You mentioned all 3. You hit on all 3 of them.
Yeah.
Well, on that note, we'll end things for episode 17. Thank you guys for listening.
Thank you both. A lot of fun.
For having us, it was great.
Yeah.
Thanks again for listening. Person, time, and place. We'll see you next time.